Okay, welcome back everyone. And now to our next speaker. Associate Professor Werner Bischof is a periodontist in practice in Geelong. He is the Oral Health Advisor Specialist Care for DHSV and a consultant periodontist of the Dental Unit, Royal Children's Hospital. He is also Associate Professor in Periodontology and Academic Lead in Periodontology, Periodontics, Department of Dentistry and Oral Health, La Trobe University. Werner is also Chair of the Victoria Registration and Notification Committee of the Dental Board of Australia and a member of the Accreditation Committee of the Australian Dental Council. Please welcome Associate Professor Werner Bischof.
Thank you for that, Angela. It's always difficult to come back after the afternoon tea session, so I commend you for coming in for this last session. Over the break, I was reflecting on some of the excellent presentations that we've had this morning and in the stream that I was in this afternoon that really challenged us to review the way we do and what we do in public dentistry. And part of my short presentation today is to have a look at how clinical leadership and the clinical leadership framework of DHSV can support our journey from here. The title of this conference, Journey to Value, implies that, and Deb mentioned, that it's a journey that we're embarking and travelling beyond this conference. And so my presentation really looks at how clinical leadership and the clinical leadership framework for DHSV can help with that. I think it's important as we travel along this journey to value that we have a very clear and common understanding of what our purpose is from an organisational point of view in our clinics and individually. And so part of the reflection that I went through is having a look at what might be our purpose, and the strategic plan document that was released last year reconfirmed that our purpose from an organisational point of view is to improve the oral health for Victorians and prioritising those of greatest need for better health. But what does oral health mean, and do we have a common understanding of that? And in particular, especially with the presentations that we had this morning, what is the understanding of oral health for those that we care for? Now, the World Health Organization emphasises that health isn't merely just the absence of disease, and the International Dental Federation last year released their definition of oral health, and I think importantly it starts off with the recognition that oral health relates to ability to speak, smile, smell, taste, touch, chew, swallow and convey a range of emotions. It's to be able to do that with confidence. It then recognises that it's the absence of discomfort, pain and disease, and it recognises that it's not only related to teeth or just the oral cavity, but it's related to the craniofacial complex. It understands and recognises that oral health is part of general well-being. It's an attribute that's associated with the psychological, physiological and social constructs of quality of life, and that it's dynamic. And that's important for us to consider, that it's influenced by experience, perceptions, expectations and the ability for the people we care for to be able to adapt. And so if we consider that our definition, our understanding of oral health contains all of these components, ability, confidence, to be without pain, discomfort and disease, and I put to you that our purpose, our why, is really to enhance and improve the dignity, well-being and quality of life of those that we care for. We do that and we aspire to do that in a supportive, integrated, quality oral health care service, and that's built on the foundation of the clinician-patient interaction. And I think that really when we think about oral health and what we're doing in public dentistry is it's the organisation community interaction and the clinician-patient interaction that we're focusing on. This isn't new, and a number of those that work in healthcare and in oral healthcare see that it's recognition of the value and importance of the clinician-patient interaction that is the point at which we can build value or create value in the care that we provide. If we fail to recognise that, then it may also be the basis where we lose the opportunity to create value And also from a quality and safety point of view, it may be the point at which harm might occur. And so from a clinical leadership point of view, it's to support the clinician and all of the clinical staff, whether it's direct clinical contact or the support staff, to be able to recognise, enhance, support and advocate for the clinician-patient interaction or organisation community interaction. The topic of clinical leadership, as presented by Diana this morning, has been topical with a focus external to dentistry. And so the external focus has been highlighted in the Targeting Zero report that was mentioned this morning, which has come up with a number of recommendations, but importantly it highlights that clinical leadership is an integral part of engaging, strengthening and directing and providing support for improvement in quality and safety in healthcare, and that applies also to dentistry. The Victorian Auditor General's report in access to public dental services also highlights that good leadership and long-term planning is important to focus on a preventive model of care, and that it's the collaboration between the organisation, clinicians and the patient and the community which is a foundation in supporting the adaptability to new models of care. So clinical leadership externally has had a focus. It's also had internally a focus in DHSV, and that's highlighted in the strategic plan that was released last year. So the internal focus, our strategic plan presents our values of transformation, of respect, for accountability and for collaboration, and they're the pillars around which we develop our value-based model of care or value-based healthcare delivery. In the strategic plan, there are a number of goals that have been set out, and those goals sit underneath or within the 4 strategic themes: the improvement of health outcomes, improve the experience, in particular the experience of those that we care for in the community, to be global leaders and local partners, and then for the organisation to be a great place to work and a great place to work with. And again, these are key within developing and understanding and enhancing the relationship, the interaction between clinician and patient, or our organisation and the community. And the strategic plan highlights that one of the enablers to achieve these goals is clinical leadership. Now the active road to clinical leadership in DHSV has been something that has been in train over the last 4 to 5 years. We had the Public Oral Health Conference 2 years ago. Its title was Clinical Leadership. We had the appointment 4 to 5 years ago of the Chief Oral Health Advisor and the Principal Oral Health Advisor DHSV. My appointment came 3 years ago as Oral Health Advisor in Specialist Care, and then last year we had the appointment of the Oral Health Advisor statewide and the Clinical Advisor Primary Care and Teaching Clinic for RDHM. And so with the appointment of those last 2 oral health advisors, it was identified that there was an opportunity to build a core group of oral health advisors across the organisation. And with some work that was done towards the end of last year was the formation and development of the Oral Health Advisory Council. And this conference is an opportunity for me to present the Oral Health Advisory Council and what the role and our responsibilities are. Part of clinical leadership and part of the work done by the Chief Oral Health Advisor, Paula Barkia, 2 years ago was the development of the clinical leadership framework. And that now is part of the responsibilities of the work done by OHAC. So who are the members of OHAC? So we have 5 oral health advisors across the organisation. The most recent has been the appointment of Martin Hall to the position of Chief Oral Health Advisor. And Martin's had a long period of time in public dentistry, and I congratulate him on his appointment to Chief Oral Health Advisor and welcome him to OHAC. Coming into OHAC, he is Chair, and he has a invitee position to the Executive of DHSV. Rana Yawary is the Oral Health Advisor statewide. She's the Principal Oral Health Advisor to the agencies and provides advice to the Chief Operating Officer for DHSV. David Butler is the Principal Oral Health Advisor for RDHM, provides oral health advice to the Executive Director of the Dental Hospital. David's also the Chair of the Clinical Leadership Group, RDHM, of the Infection Control Committee, the Antimicrobial Stewardship Committee, and also PTAC. Matt Hopcraft is Oral Health Advisor of Primary Care and Teaching Clinic. He's Primary Advisor to the Manager of Teaching Clinic and Primary Care, and also has close collaborations with the University of Melbourne and also the RMIT dental programs, dental and oral health therapy programs. A number of the presenters this morning looking at the development of value-based care emphasise the value of data. And so an integral member of OHAC is Martin Whelan as the clinical data analyst, to be able to provide us with the clinical data and evidence to support the advice provided by OHAC to executive and to the board. And then there's my role as Oral Health Advisor Specialist Care. I have oversight of the specialist units within the dental hospital and also have close collaborations with the Melbourne Dental School postgraduate programs. So OHAC is the peak oral health advisory body to the board through DHSV's executive. Our role is to provide advice from a clinical and operational perspective to support DHSV achieving the goals set out in the strategic plan. Our key areas of action is to provide support and to engage the clinical workforce within DHSV for the implementation of innovative models of care, to look at the development of the oral health workforce to support these new models of care, to look at collaboration with community, and also to ensure that there's an opportunity to be able to evaluate and review the oral health outcomes. And then our responsibility is to really evolve and develop, drive and review the clinical leadership framework in the way that it supports the clinical staff across DHSV. Now, I mentioned earlier that the early work done by Paula Barkia was the development of the clinical leadership framework. And part of her work then came up with a definition for what the clinical leadership framework means for DHSV. And it raises, it was a definition developed by Paula 2 to 3 years ago, but it again utilises similar language to what we've seen this morning. We're looking at driving the workforce as a total, so not just dentist focused, but it's across the whole clinical workforce and non-clinical workforce to be able to share and utilise the knowledge and skills, to develop standards, which is what ICHOM is helping us to develop, for consistent evidence-based quality service, which engages the community and with patients. Initially, when Paula developed this and presented to executive and to board, it was focusing on the development of a clinical leadership framework for RDHM primarily to start off with, and that the framework really came up with 2 domains. The domains was to support the individual clinician, and that was through a variety of different programs and support structures for the individual clinician, which included an understanding of the scope of practice, the process of credentialing, the professional development and peer support, both formal and informal, that clinician can rely on within their clinical setting. Also recognising that the individual clinician works in a clinical team, the other domain that was presented was the group peer support, that it relied on some of the clinical indicators and the clinical guidelines. It took into consideration some case reviews and even some complaints and also adverse event screening that might occur in a clinical setting. The clinical audits provided an opportunity then to be able to support the clinical guidelines and pathways. And all of this was revolved around the development of new models of care. OHAC has taken on its responsibility to look at this clinical leadership framework and develop it further, so it's second version really. And the discussions in OHAC really was that we needed a clinical leadership framework that spanned across the whole service, not just RDHM focused. It needed to be able to integrate into some of the programs that were already available within DHSV and some of the policies of DHSV and the direction that we were going in. And so I'm presenting to you today a quick overview of what that clinical leadership framework is the version 2 by OHAC. It still is based on our purpose to improve oral health for better health, or my version of that, which is to enhance the dignity, well-being and quality of life of those that we care for. It takes into consideration as pillars our values, so respect, accountability, transformation and collaboration. And ultimately what we're aiming to do is to improve oral health outcomes. And that's taking into consideration the broader definition as described by the International Dental Federation. So the abilities, the consideration with regards to quality of life and well-being, and also the consideration that it is the absence of discomfort, pain and disease. OHAC has developed 4 domains, and that's really the recognition that the support of the clinician and the clinical staff really begins before recruitment. So the first is the recruitment and the alignment to our values. It's taken into consideration that our position descriptions, our job interviews, our credentialing all aims to look at supporting the value-based healthcare model that we're all aspiring to. That onboarding and orientation takes into consideration the new models and innovative models of care that we're developing and that we saw in both of the workshops this afternoon. Part of the aligned work that's been done in DHSV is then the respectful clinician framework, which again aligns to the values and the culture that we're developing or wanting to develop within DHSV. We then have the recognition of the individual clinician as they come into the workforce. They're supported again by the same type of areas that were presented in the version 1 of the clinical framework, which is informal and formal peer support and review, collaboration and referral, the opportunities to work within teams, professional development and performance appraisal, and really to be able to develop and beyond the initial scope of practice in coming into the service. Recognising that the clinician works in partnership with the organisation, the involvement with the clinician in the development of the service is vitally important. The third domain then is the recognition that the clinician works within a clinical team, and again within that clinical team there's an opportunity to be able to develop scopes of practice, to be able to look at the clinician's scorecard, to be able to reflect on performance, to be able to look at professional development, and again peer review and collaboration with other members of the dental team. And the final consideration then is that that's done in collaboration and partnership with our patients or with community. And many of the projects that we looked at in the session that I was in this afternoon identified that there was a strong value in being able to collaborate with community. The last domain is then what the service can provide in supporting this framework. And that's really looking at the engagement of clinicians, the involvement in clinicians in some of the committees and groups, in the development of the clinical leadership program and into conferences such as we have here. And this is really to be able to present, test and to expand new and innovative models of care and system redesign. So where do we go from here? Really it's from the point of view of presenting this framework. There'll be more of this material that will come out to the agencies and to the clinicians through the intranet, through the website, through other forms of communication. There's the opportunity to be able to engage with OHAC and with the clinical leadership framework through membership of a number of the committees, the Public Oral Health Leadership Group, through the Clinical Leadership in Practice Committee, and in the dental hospital through the Clinical Leadership Group. If there's interest, there's an opportunity to be able to provide mentoring and peer support, and also with the launching of the Clinician Oral Health Leadership Program is involvement in that program as a platform for development. And for the individual work that we do as oral health advisors is the opportunity to be able to make direct contact with us. So hopefully there's an opportunity now to be able to see where the support of clinical leadership and clinical leadership framework will engage the journey that we've started today with the consideration of value-based healthcare. Thank you.
Don't disappear. Thank you very much. Terrific. Thanks, Werner. Okay, well, you've seen her on the screen. Now let's meet Rana Yawary. Rana works in collaboration with the statewide team to embed the clinical leadership framework across public oral health, implement new models of care and drive initiatives relating to oral disease prevention and improved health outcomes. She's a paediatric dentist and works both privately and at the Royal Dental Hospital of Melbourne. Prior to joining DHSV, Rana held senior positions at the Western Australian School Dental Service and at the Royal Children's Hospital of Melbourne. Please welcome Rana Yawary. Hello, now we're doing this together. Yeah. So, you can have the podium.
Thank you. So, the recently released results of the National Child Oral Health Study thank you, tells us that there is a compelling argument in terms of improving children's oral health and giving priority to actions that are more universal, so they reach larger numbers of children, actions that are more passive, so they require less individual effort, and actions that are more proportionate, so they benefit mostly those with the greatest burden of disease. So today we're just summarising the key findings of the 2012 to 2014 National Child Oral Health Study based on a question and answer session with Angela.
Well, let's start in the obvious spot. What is the study? Tell us about it.
So the National Child Oral Health Study was a massive study, cross-sectional snapshot of children aged between 5 and 14 years across Australia, and it involved 24,664 children across 861 schools. So you could say it's a representative sample. And it was conducted by the Australian Research Centre at the University of Adelaide, and the Victorian segment involved over 4,400 children across 150 schools. And that was conducted by DHSV in partnership with the Department of Health and Human Services.
Have you got slides?
I do. There we are. And this is not to be confused with the Victorian Preschoolers Oral Health Survey, which involved preschool children across 61 kindergartens in the most disadvantaged areas.
Yes. So why was this huge initiative undertaken?
So caries is the most prevalent and the most important oral disease in Australian children. It's more than twice as common as asthma in children over the age of 6. We know that poor oral health in early life is a strong indicator of poor oral health in adulthood. So what your teeth look like at 5 years old is a strong indicator of what they're going to look like at 25. And we also know from John Rogers' recent study that dental disease is the main reason for preschool children to receive a general anaesthetic. So looking at the current state of affairs, the grand challenge then, I guess, is to make sure that from an organisation perspective we try to do better than we have. And the key to being able to do that is information and knowledge. So we need to know what the oral health status of our population is, we need to know what their oral health behaviours are, and what their access to services is like, because those are key to improving the rate of oral health or disease in Victoria.
Let's jump forward to the next, let's see, here we go. Let's talk about the difference between Victorian and national data. So growing up in South Australia, there was a myth that went around that we had better teeth because of the fluoride in the water, but I think it may have had more to do with the fact that a lot of schools had dental clinics attached to them. In the 70s, it was the Don Dunstan decade. Money went into health and we all benefited from that. Is there a difference between Victoria and other states?
It's actually really interesting that you say that. Let's look at the results. So, for example, the percentage of 5 to 10-year-old children with decay experience in Victoria is 43%, slightly higher than the national average. We've also got a comparison there from Victorian public health data from titanium during the same sort of period, which shows significantly larger, 54%. I think that can be attributed to the fact that kids that actually visit our services already have a problem most often, so that can skew the results. A positive from the results, a positive difference, is that fissure sealants, the percentage of Victorian kids with fissure sealants is significantly higher than the national average, so 40% in comparison to 27%. But as you said, South Australia and the Australian Capital Territory have the lowest rate of primary tooth decay. In fact, South Australia does significantly better in all children of all ages compared to Victoria and the national average. So it's interesting that that's come up and whether it is a school dental.
We were always told that, but I didn't realise there were studies to actually back it up. That's terrific. I'll smile more. Do you believe there's been an improvement over the last 20 to 30 years? And we'll jump forward to the next slide.
Okay. Well, this represents an analysis of trends between the current survey and previous national oral health studies. And this one shows a significant decline in primary tooth decay since the 1970s to the late 1980s. That was captured. There was a further decline until the 2000s, followed by an increase until 2010. In terms of permanent teeth, you've got reduced significantly caries experience, sharp decline from 1970s until the late 1990s, and since the year 2000, fluctuating rates until the year 2010. So what the current national child oral health study shows us is that there is an improvement in dental caries experience since 2010. So a significant decrease in the prevalence of established tooth decay in older children and less so in younger children has been observed. But despite these improvements, about half of all children still have signs of tooth decay.
I asked about this earlier because I have a 4-year-old son, and now I've got you on the stage so I can continue this. When and where are kids actually going to see the dentist?
Okay.
Talk us through it.
So, all right. So essentially, almost half of preschool-age children don't visit a dental professional. So almost half. It's significantly better in Victoria. You can see here it's about 64.7% compared to the national average, which is very good. But of those that actually do visit a dentist, over 1/5 of them don't actually visit regularly, so they don't actually go back for their recalls in 2 years. But the standout difference, I guess, between the states and territories is more about private versus public use of dental services. So the proportion of children that last visited a private practice is significantly higher in New South Wales and Victoria. And I guess when you talk about South Australia, the public coverage had more to do with the involvement of more traditional school dental services. So South Australia and Western Australia were one of the lowest. Yeah.
Did the study reveal anything about oral health literacy or health behaviours in this cohort? I'll jump forward to the next slide.
Okie dokie. Okay, so it's recommended that children's teeth are cleaned as soon as they erupt, so around 6 months of age. It's also recommended that they start to use toothpaste around 18 months of age. And lastly, it's not recommended to start toothpaste any further than 30 months of age. So you have to start between 18 months and 30 months. So what we found from the study was that 1/3 of school-age children don't brush their teeth twice a day. 1/3 of children start toothpaste after 30 months of age, but 60% of parents indicated that they believed their child's oral health was excellent. So I guess you could say that there's generally poor compliance with recommendations. And again, Indigenous children, children whose parents were born overseas, those who were from lower socioeconomic areas, they delayed the introduction of toothbrushing until much later. And what the study tells us is that we should really use social marketing because it's a powerful tool in trying to establish toothbrushing behaviour appropriately. So because of that, I think it's important to use the results of the studies, because they have been extensive, to try and establish some key, simple, evidence-based oral health messages that we can all utilise so that we give them the same message to try and address some of the issues. So we know from the Victorian Preschoolers Oral Health Survey that only 40% of parents assist their kids in brushing their teeth twice a day. So a message should be, assist your child to brush their teeth until they can do it themselves. When can they do it themselves? Around 7 or 8 years old. For school-aged children, brush your teeth along the gum line at least twice a day. Again, children should start cleaning their teeth as soon as they erupt. Tell them to start using toothpaste at 18 months of age, children's toothpaste. And in terms of visiting patterns, we know from previously that everyone is different. Their background, where you're born, what ethnicity you are, your parents' education level, all determine your risk of oral disease as well as your literacy. So rather than giving a set recall period, everyone has different oral health needs and risk levels. Talk to your own oral health professional about your risk level and how frequently you need to visit the dentist. So these are just some simple messages that we can try and promote, and I think it's important that they're not just simple, but that we're all giving the same sort of messages as well.
Terrific. Anything else you'd like to add? No? Happy? Thank you, Rana. That was wonderful. Thank you very much for joining us. I'm feeling much better about my parenting after today. Thank you. That's good. Okay, our final speaker, Karen Laing, is going to talk about building a patient safety culture. Karen is the Director of Nursing, Quality and Community Engagement at Kyneton District Health, serving a community of 45,000 people. Services provided by Kyneton District Health include acute inpatient care, maternity, surgery, dialysis, palliative care and community nursing services. Please welcome Karen Laing.
Thank you, and thank you for inviting me to speak today. It's been a terrific day full of some tremendous speakers, so I'm feeling very nervous that you're going to conclude with me when it's the end of a Friday and the end of a long week and the end of a long day. But I hope I can keep you interested for another few minutes before we go out to the refreshments in the foyer, which I'm looking forward to. I'd like to also acknowledge the traditional owners on the land on which we are gathering today and pay my respects to their elders, past, present and emerging. Kyneton District Health actually is in a unique position as it relates to the traditional owners. We sit on the Campaspe River, which is very nice, and it's the border of the Dja Dja Wurrung and the Taungurung people. So we acknowledge the Djara and the Taungurung as our shared traditional custodians where we operate, and that's where we operate, up there. We were invited to speak to you today, I think, because Marie Cudahy is our CEO, and she assisted Stephen Duckett and Professor Harvey Newman with the Targeting Zero report, the review of the safety and quality of Victoria after the cluster of avoidable perinatal deaths that Diane Watson alluded to earlier in her speech this morning. So Targeting Zero is the result of that review. Unfortunately, Marie was unable to speak. She's on a training forum this week, so she handballed to me, which I think means she might be up for the AFLW next year because she mastered handball beautifully. So Erin Phillips better look out. But I'm going to tell you about our journey on an improvement culture, which is something we've been talking about, and I think hopefully you'll see a few threads through my speech today that make sense and link to some of the other things we've heard today. You already heard a little bit about us in Angela's introduction about Kyneton District Health. We're a small rural health service by definition. We're located about halfway between Melbourne and Bendigo, almost exactly halfway in fact. The picture on the left in the slide above there is the original Bluestone Hospital that was built beside the Campaspe River nearly over 160 years ago. And the one on the right and on the earlier slide at the intro is our new hospital with a brand new ambulatory care centre and an award-winning architectural design which depicts the Macedon Ranges as you approach from Melbourne. That's the roof line of it. That doesn't look as nice in that photo, but it does look nice there, and it really does look like that as you approach coming out of Melbourne. We've already told them, 45,000 people that we serve, etc. We're classified as a peri-urban community, which is a new title for us. We weren't sure whether we liked being peri-urban, but we do now. Peri-urban means that we sit on the perimeter of urban Melbourne and we straddle metropolitan and regional settings. So we think we're a regional hospital, but we point south because a lot of our clinical work, things move to the south more so than it does to the north to Bendigo. We're a public hospital, we provide community care and we collaborate with many of our partners. And all of this just sounds idyllic. I know you all just want to come and play now. However, we had some challenges and I'm going to tell you about them and how we have overcome them in the last 2 or 3 years. So it's fair to say that we had a few challenges. We had significant difficulties engaging with our community and our consumers in recent years. I hasten to add this was under former management, but just, fess up right now. And in 2013, the Macedon Ranges residents were expressing significant concern about the management of the hospital to the point that they formed the Committee for a Better Functioning Hospital, which was rather overwhelming. And they wanted to push for improvement on the way the organisation was managed, and push they did. 400 plus people attended the AGM in 2013 bearing placards, which is not particularly pleasant, and it's a significant turnout for any AGM, let alone a small rural health service in Kyneton. So the problem was we faced financial difficulties, we had a significant and a recurrent deficit. We were widely criticised in the media because a bad news story is always better press than a good news story. The hospital after hours GPs had withdrawn their services, and there was discontent about the closure of an aged care facility that the organisation was operating at the time. And as that wasn't enough, we were given 90 days to review our governance systems or we would not be awarded accreditation. So eventually that culminated with the majority of the Board of Management being turned over and an entire hospital executive, new executive were appointed because something needed to change. So that's an opportunity, if ever there was one. So upon appointment of Marie Cudahy, the new CEO that I spoke of earlier, and a majority new board, a couple of the members of the board remained on, but most were turned over. They were set a clear mandate for the future, and the objectives being openness and trust, and the mandate being restore community confidence, turn around the budget deficit, and especially improve quality and safety, which will be a fair part of what I tell you about. So how we did that was we worked with our staff and the community stakeholders who had an interest in a better functioning hospital. And the new board developed together, we all developed a new strategic scorecard with key deliverables defined for each of those strategies. The goals that we set ourselves were community engagement, financial performance being improved, a review of our quality governance systems, that one had to be done pretty quickly, empowering staff to work together to achieve those goals together as a team, working with rather than against our strategic partners, and underpinning all of this was to setting a positive patient experience as our measure of success. What we know now, which we didn't know then or recognise then, was that by defining those strategic objectives that I just outlined, the path we had set ourselves was to be what's now known as a full spectrum organisation. I thought one of the previous speakers to me may have talked about a full spectrum organisation because it is pretty topical, but I'll tell you a little bit about it. We weren't focusing on just one thing. We were deliberately setting our objectives across a range of areas. That's the definition of a full spectrum organisation. With the defined by Richard Barrett, he talks about an organisation's success being reliant on having a consciousness for the values of survival, being financial stability, relationships, focusing on open communication and customer satisfaction, organisational self-esteem, being looking at your performance, your quality, excellence, best practice, enabling you to hold your head high when you say, that's where I work. Transformation, being adaptable and innovative, empowering staff and supporting them to participate in their continuous learning. Internal cohesion, where the culture is based on shared values and a vision that engenders a climate of trust. Making a difference, which relies on alliances and partnerships. And service, which is about social responsibility and looking to the business impact on future generations. So all those factors are said to make an organisation attractive to employees, to customers and to investors, if you're looking for investors. Full spectrum consciousness is said to be good for people, good for society and good for business. We're not sure if it was a coincidence that the strategic priorities that we had set aligned with these levels of consciousness, or perhaps it really is that great minds think alike. Turning our minds to the key strategic priorities, I'll now outline what we did to turn the ship around and to avoid the iceberg that was looming. The first of the key deliverables you might remember was community engagement, and T for 10 is what we did to address that. It's a community consultation project, a significant project we conducted over 3 years, and it was seen as a way to get authentic grassroots feedback. It's based on the kitchen table conversations methodology some of you may have heard of. It came to prominence in the US originally, and here most recently at the federal election before last, where Cathy McGowan used this methodology and defeated Sophie Mirabella in the seat of Indi election before last. So that's the kitchen table conversations. What we did was we recruited hosts and developed their own invitation list and welcomed a group into their own home or a community space to have a conversation about Kyneton District Health. No Kyneton District Health staff were present for those conversations. We wanted to create a safe place for the participants to say what they think. We funded the morning tea or the supper, as the case may be, providing money for the host to purchase refreshments for their guests. We provided a guide sheet and the rules of engagement and 3 targeted questions that we wanted the answers to. We briefed the hosts in previous sessions so they could guide the discussions, and they nominated a scribe and brought the comments back to us, where we collated them and we themed the verbatim results. We got in excess of 400 individual comments that came back to us, ranging across a wide range of things. The 3 questions that we asked, though, of the people who participated in those conversations was, what does KDH do? What do you know or hear about what we do at Kyneton District Health? How does KDH do it? What's been your experience of Kyneton District Health, or what have you heard from others? And what could KDH do? What do you and the broader community need from Kyneton District Health? So based on extensive and at times quite frank feedback from these forums, our strategic and quality plans were revised. The new initiatives that we developed included the development of a Consumer and Community Advisory Committee and the recruitment of new consumer reps to that. And 2 of the leaders of the Committee for a Better Functioning Hospital joined our Consumer Advisory Committee and have been really very, very proactive and remain members of our advisory committee today. So that was a significant turnaround. We revamped our branding and our publications and built on traditional and social media profiles, got a Facebook page, really up with the times. Particularly successful, though, have been our activities where we've invited the community in to our organisation. We had a garden planting project where we ran out of trees. We purchased 100 trees for people who might like to donate and plant one in honour of someone or for an event or something, and we ran out of trees and had to buy more on the day and run down to the nursery because we had in excess of 200 people attend wanting to plant a tree in our gardens from the community, which was lovely. We now have a very nice garden. And the other event that was really popular was our Check Out Our Insides open day. And we had more than 120 people come through to see behind the scenes in areas that they normally wouldn't get to see in a hospital, which they found very interesting. So they're the sort of things that we've been doing. The second of our key deliverables was to improve our financial performance. Like all of you, we've had to find ways to deliver quality healthcare and services while continuing to find efficiencies. We're a public organisation and we're funded via a block grant as a small rural health service. We don't receive activity-based funding or funding based on the number of patients we see or anything. We have to pay for all of the services out of a fixed grant. So we have made significant improvements across a range of departments, but the most successful or biggest contributor, I suppose, to our improved financial performance was a review of our surgical work. We needed to start saying no to some things, so we commissioned a review of our surgery and looked at our own capability framework and the scope of practice of our practitioners, and the recommendation was that we reconfigure the mix of surgery that we offered so that we remained relevant to the community that we serve, but we were able to do that in a financially sustainable way. We also were able to negotiate reasonably with surgeons to revise their contracts, which does prove that a reasonable surgeon is not an oxymoron. Who'd have thought? And we've also successfully bid for fee-for-service surgical work from both Western and Northern hospitals, and together, so that's additional revenue for us. We take the revenue from them for the work that they had on their waiting list, and we've been able to do that for them, and that's really enabled us to turn around our budget performance. We now are actually running ahead of budget, and we have repaid the deficit that we owed to the department, which is a good position to be in. The third of our key deliverables is for around quality and safety, and this is where the bulk of our work has been done and where hopefully this may be of the most interest to you today. When we were advised that we needed to review our clinical governance framework and systems in order to achieve accreditations, that was a pretty good incentive to do something fast, and we had 90 days to do it. So we went back to the beginning and we used Kathy Boulding's strategic quality framework. I've got a copy of it here today if anybody wants one. And she's written a book which is a 6-month blueprint for developing a strategic quality framework for a governance system. We worked with our staff to build on the theory and to tailor it to our setting or to Cantonise it and put our own stamp on it. We followed that book step by step over the 6 months. The result is what we call our best care framework, which moves staff from a ticker box mentality, a compliance approach, to providing patient and consumer experience that we just define as personal, connected and right and safe. And our staff have come up with these definitions. Personal, meaning a patient, that we put patients at the centre of their care and involve them in meaningful ways about the decisions that they make. The connected and right refers to patients getting coordinated care at the right time based on the latest evidence and knowledge. And safe means that we ensure that patients and their families and carers are safe with us, and if something does go wrong, we take action to prevent it happening again or to someone else. So this is part of our new organisational vision, and what, as I said, underpins everything is that every person has a positive experience every time. This is the framework. The content of that framework was developed with input across the organisation from staff and patients on what constitutes quality of care. What does quality look like? We know from literature that patients want compassion, clarity, collaboration, continuity, and that healthcare professionals want to provide experience that's safe, suitable, successful. When we put staff feedback together with the literature, the goals of our best care were developed. So the components of the best care framework that were developed point deliberately point to on the right, our purpose, which is an experience that is personal, connected and right that I've just described. Back from that are the people who create and support that purpose. Together we came up with the key attributes that we felt staff needed to be able to deliver best care. These are written into our position descriptions: empathy, skilled, informed, proactive and accountable. And behind that is the quality governance systems, or pillars, we call them, that provide the platform for our people to create and support best care. So it works from the purpose backwards. Everything is there for the purpose rather than the other way up. This is a very quick slide, and you might not know how well it came up on the big screen, but it's just to show that all of the elements of our quality system fit together and fit into one or other of the best care goals or the governance pillars. So we reviewed all of our committees, policies, audits, quality projects, tools, forms, everything, to see where they fit, and we have defined the measures that we monitor and report under each of the goals and pillars at our various committees. Along with the diagram of the framework on the previous slide, this has helped staff understand the quality governance system, and it shows how everything is linked together and works together to support best care. So the language we speak is best care rather than the national standards as we're accredited according to. We want to turn the language around and see where the national standards fit with our best care. So with these initiatives in place, we went on to be accredited in 2013. We did get the 90-day tick, but that was a provisional accreditation. But we've subsequently gone on to pass all 10 national standards at our last survey last year, and we even scored 2 met with merits from the surveyors. So we had no recommendations in our last accreditation and 2 met with merits, and invitations to speak at places like this now. So you get that as part of your punishment. Our current work includes the identification of patient-reported outcomes, so that's where we're working to now, and to measure and monitor them, as well as patient stories. So we're trying to build on the patient satisfaction surveys that are done and actually get a little more texture to patients' experience by gathering patient stories using our consumer reps as volunteers who we've trained to go out and interview patients to monitor their experience, that we can report back out the learnings that we gain from that to the board and to our staff. The fourth key deliverable was to empower our staff to be the best that they can be. Of the 4 governance pillars we identified in the Best Care Framework is an effective workforce. So again, I emphasise these were created by the staff. These didn't come from a textbook. They determined that effective workforce is something that we need, and this is what it takes. So the elements were necessary to ensure that an effective workforce includes recruitment, credentialing and performance review. We've revised all of those. Training, professional development and supervision, and most importantly, a culture of safety and quality, which I will speak to a little more in another couple of slides. But first, we noted that everyone has a role in creating best care. We've defined what this means from each member of that team, including patients, from their own perspective. So we spell out clearly what patients can expect from us, what best care will feel like to them, that they will feel respected, that their needs will be met, that they will receive information in a way they can understand, and that helps them make decisions. Staff at the point of care, or frontline staff, have the greatest impact on those that we care for and their families' experience, whether in a clinical or a non-clinical role. So all staff, clinical and non-clinical, are called upon to respond sensitively and respectfully to patients and families, and to involve them in decisions about their care. That's a bit of a shift for many people. It's in the medical system. I don't know whether it's the same in dental, but in the medical model, more often than not, it's quite a patriarchal model, and we generally think we know what's best. So it's a shift to put the patient at the centre and to be really calling for them to be involved in their decisions about their care. Managers are charged with considering patients first when developing our systems, rather than considering the organisational needs first when we're developing our systems to support staff, and to support staff to communicate with the rest of the team. We know that communication, or the lack of it, is the greatest risk to patient safety, particularly at the transition of care from one shift to the next, or the transfer of care between service providers. Our board members are responsible for ensuring systems are in place to support staff at the point of care and for managing the effectiveness of those systems. Reflecting on the fact that one element of an effective workforce is a culture of safety and quality, that we look to our People Matters survey to see how we're doing. That's the public sector People Matters survey. Our survey results now are positive on two fronts. They weren't. More staff are making the effort to complete the survey to be heard. That speaks to trust and openness that we have developed. We've gone from 15% response rate to a 50% response rate for each of the last three surveys. 50% could be better, but we're happier with 50 than we were with 15. At KDH has significantly improved from under 70% to 96% in 2015 for the questions in relation to how the culture and practice of the organisation support patient safety. We believe we are still improving, but they went and changed the survey on us in 2016 and added a neither agree nor disagree option to the questions, to the responses, so the results can't be compared to previous surveys. So even though we can't compare to previous surveys, we can still compare ourselves to our peers in 2016 results, and for the same questions, we rate 10% higher than our peer average for 7 out of 8 of those questions. So that's a significant improvement on where we were, and we think speaks to the work that we have done, including our staff. The fifth, nearly there, the drinks, I can hear them popping, the corks. The strategic partnerships was our fifth key deliverable. One of the important markers of our development as a health service is our improved relations with GPs, remembering that they withdrew their services 3 years ago. We're more directly connected with them now, sharing information with regular newsletters and forums and visiting the medical practice ourselves rather than waiting for them to be on site to have a chat to them. We provide update information about our capacity and the quality of our services, and we are very transparent in our performance, in our quality work and performance with them. A local practice has recently moved on site to our hospital precinct, which is a visible presence to the community that doctors support and that they are part of their local hospital. That was very important for our community, that they thought the doctors didn't support us, so they didn't support us. By having a doctor's clinic on site, it sends a very, very strong message. Much of this, we have also joined with other agencies, sorry, missed a sentence. We also joined with other agencies in the Macedon Ranges with collaborative initiatives such as community safety, working with the police and the council on that. We're a member of that committee. Domestic violence strategies, drug and alcohol strategies, and the municipal wellbeing plan. So that's new work for us as an acute hospital. They're not normally forums that we sit around the table at or partners that we normally sit with. It's been great for us, but I also think that it's been pretty good for them too. We discovered that we're often addressing the same problems a little differently, using a different funding stream with a few different directives from our various governing agencies, and that we work better when we collaborate than when we're competing for the same sort of market or community or survey respondents and things. So that's been really good. The patient experience is our last and ultimately the most important key deliverable that we set ourselves. A positive experience every patient, every time. The Best Care Framework deliberately set personal care as the first of our best care goals, and all efforts have been directed to strategies to enhance the patient's participation in their care. We did an enormous amount of work in developing strategies to assist in health literacy, or understanding your health care is what we called it, to take ourselves away from the references to literacy and the negative connotations that sometimes has. So the Victorian Health Experience Survey tells us we're on the right track, we think, with that. This quarterly survey run by the Department of Health surveys adult inpatients randomly selected and shows that KDH is consistently rated greater than 95% since September 2015. We haven't gone under 95%. And our health literacy initiatives have been rewarded with our poster being judged runner-up at the VES, Victorian Health Experience Survey, Lead the Change Patient Experience Forum late last year. That's our poster. I don't know how that's come up there either, but this is our award-winning poster. We looked at the questions on the Health Experience Survey relating to understanding your healthcare, and we developed health literacy strategies to improve those results. The 3 key initiatives that we introduced were Teach Back, which is a methodology for staff in educating patients. So where you simply ask the patient to explain back what you have just taught them to check their understanding of it. Understanding My Healthcare notepads, we place at each of the bedsides and in each of the packs for our community patients when they're admitted to the district nursing team, where they can write any questions that they have to remember to ask the next time somebody is with them, the doctor or the nurse that visits them. And the Smart Discharge Advice Form is my favourite. And the Smart Discharge Advice Form summarises discharge advice that we give to patients when they go home using the SMART acronym, SMART, S standing for signs and symptoms I should look out for. M is medication information I need to remember. A is appointments I need to keep. R is routine and lifestyle changes I need to make. And T is telephone numbers to keep handy. So after introducing these 3 initiatives, we moved our results for the Understanding Your Healthcare questions on that survey from 82% to 95%. And that's what got us the award. In closing, I don't know what time I'm on. I'm not watching the clock, but you're nearly there. In closing, we learned that true partnership and collaboration are an essential ingredient for success across a number of measures. Partnering with patients ensures patient-centred care. Partnering with clinicians and health partners is imperative for cooperative and constructive relations. And partnering with the community is vital in gaining engagement and support for your organisation. We referred to Confucius when we developed our health literacy initiatives, as I've put there on that little slide, but it's true of most things. If you involve me, I will understand. And then we're all on the way to achieving great things together. And as Angela said opening this morning, making great things happen. You alluded to it earlier. So perhaps now that we have bathed in your glory, because you made the great things happen with the AWFL, etc., perhaps now that we've bathed in your glory for the day and you can bathe in a little bit of our glory for the last 3 years of our success, that in the last few hours maybe our chances of success have increased significantly with what we've learned today. There's the references for the material that I've provided today, and I thank you for your time. Thank you. Thank you very much.
Absolute pleasure. Well, thank you, Karen, and congratulations in turning things around and regaining the trust of the local community. That was an inspiring way to end that part of our day. Well, for her concluding remarks, please welcome CEO of DHSV, Deb Cole.
Thank you. I think Karen misled us. She's sort of indicating you'd get a drink now, but I'm afraid you've got me between her and the drinks. Firstly, I'd just like to thank everybody for coming today. I think it's been an amazing day for all the different ideas, and I suppose the journey that we're now on, you can see it's a journey that's happening right across the world. It's not just here in Australia, and it's not just here in oral health in Victoria. But I think the advantage that we have got is we're really at the cutting edge. I shouldn't use those sort of terms in an oral health forum, but we are at the cutting edge of this sort of journey. And I think we've got a real opportunity to, in fact, create the journey we want to go on. And I think there's been some really clear messages from different people throughout the day. And I'm just going to just pick up on a couple of them that I've heard. But one of the things, when Jacob was talking to us this morning, he talked about making data transparent to both clinicians and to patients. We actually need to hear from our patients and our consumers about their quality of life, because that's a really important thing. And I think that's one thing in oral health that we haven't done a lot of, and that's something that we really do need to put more effort into. We're obviously working with ICHOM at the moment, and I sit on the working group at the moment, and two of our consumers from Victoria, from DHSV, are also on that working group, and we sit on that with a whole pile of people from right across the world. The same map that Jacob showed you, we are in the same country, so virtually every continent in the world is represented, and so it's so intriguing talking to people from different countries with different issues, but actually when you look at it, it all boils down to the same thing. When we heard from Diane this morning also, she talked a lot about that huge variation in healthcare, and a lot of this interventions that we do, and you can see it, different outcomes in all sorts, even in different neighbourhoods, you get these huge outcomes, and you sort of sit there and what value is that to a community? And there isn't really. We actually need to be having conversations about those variations. And when Rana was showing the Child Oral Health Survey data, you could see there's South Australia's better. Like, why? Why is South Australia better with their DMFT than we are, or other states? And I'm sure that even within the different communities within the Australia, you'd see variations. And they're the sort of things we need to explore and look at. Melanie and Harry, they offered us a toolkit. They're a lot further along than we are. They also talked about proms being used to drive the conversations. We can actually use them. Our patients can use them, our consumers can use them, and our clinicians can use them for starting a conversation. So it's a really valuable toolkit that they've offered us, and they'll be able to give us a lot more help into the future. Malcolm from Ramsay Healthcare, he is also, or they're a lot further along. They're doing a lot more different data sets than we are. But the good thing is there's this collaboration about they're willing to work with us. We have to learn from all sorts of different industries, and we have to also learn from the private sector as well, because we are all doing some really good things, and it's important that we do have those opportunities to get to talk to people that are doing it really well. With Karen, one of the things I found really interesting listening to her journey was that you listen to exactly the same values that we have in DHSV that have been formed and recreated in our new strategic plan, that have come from lots of consultation from all of you in this room. And you heard the words of transformation, you heard the words of accountability, you heard very strongly that word of collaboration and also of respect. And you can't do these sort of journeys without them. And I really like the SMART initiative she was talking about. I actually think that's got real value, and all the way through this today I've been writing down ideas that I've heard from different people, because we can use those and share them. And to all the people that presented this afternoon, I actually sent through a text to our previous chair, Mick, who this conference was actually his idea, and he badgered me about it for years, and I kept ignoring him, thinking he might go away. And anyone that knows Mick knows that he doesn't ever go away. And he was really keen on having all the innovations to be shared, because he said we could learn so much from it, and he was so right. And I just sent him a text earlier saying, I just can't believe the fabulous stuff I'm seeing here. It was your idea, and I hate to say this, but you're right. And I got a very facetious comment back. So But he was very proud of the fact that it's still going and that people are really using it. But I think the advantage of the different things that we heard today is we could actually share those things right across the state. They will become incorporated into the best model of care, the best value that we need to have to get the outcomes over the cost, because every one of those things has something to contribute, if not be one of the major models of care. So I think we must be constantly looking at what everybody's doing in the innovations, because that, those ideas are really the future. So I suppose from where are we now? We are very focused at DHSV in creating a values-based health system. I don't think it's a choice. I think when you looked at the data this morning, we don't actually have a choice now. It's pretty essential for the future of healthcare in Victoria, in fact across the globe, that we go down this track. It is time for all of us to step up to the plate and make it happen. I'm not saying it's going to be an easy journey, and you could hear that from the people this morning that are already on it. It's not an easy journey, but it is a journey that we have to be enthusiastic and take on. And you can hear already that we're working together a lot, and there's some real opportunities for us to do even more. So today was a little bit about having the first steps of understanding what values-based health system was all about, and what we are doing at the moment about developing some oral health outcome measures. And our intention, in fact the plan, is that by the end of this calendar year we will have those outcome measures. And with one of the things that Werner was showing before, he was talking about the new FDI definition of oral health. And that is the definition that we are basing all of these health outcome measures on. And in fact, the really good thing about this consortium with ICHOM is that we have now joined with FTI. They are part of the group, and I met face to face with most of the contributors last week, and it was just amazing having all of these people that I've read about in textbooks all sitting around a room discussing in depth what's going on, and having consumers there holding us all to account, which was even better. So I hope that you're pretty inspired to go back and start thinking about it, starting to do things. I have heard a lot of discussion today about, well, so what? What are we going to do now? Our funding model isn't right, this isn't right, we need this, we need that. But I think one of the things that Jacob said this morning is you've got to start somewhere, and you've got to start small, and there are things that we can all do. And even simple, very things, when you think of the clinical leadership program that we are sort of bringing together, and a lot of you are all involved in, is we can start looking at our data. We can start looking at the variation, either within your agencies or within the state, or within, and later on we'll be able to do it across the world. And even if we just have a conversation about why there's variation, that's a really good start. And the other thing that you may have noticed in some of the conferences we're having regionally is that we're starting to produce data for you about low value and high value services. There are lots of things we do in health that add no value, and we need to start having discussions about them. In dentistry it's a little bit harder. There are some things that are clearly low value or high value, but there are some things that are very dependent on the risk status of a person about whether it's high or low value. I mean, I look at a lot of the data and I say, if someone's a high-risk kid, why on earth aren't you throwing fissure sealants on them? Why aren't they having fluoride? And the reality is we are not all that discriminate in, I'm using a generalisation here, about how we apply those different interventions. So we actually have to get a lot smarter about how we apply the types of services and interventions we do. And for people as clinical leaders, having those conversations actually makes a real difference. So I suppose my challenge to you is please become part of this journey. Please get involved in the clinical leadership, start questioning, start asking for data, because we have an enormous amount of data. You actually have access to an enormous amount of data. What we ought to start doing is analysing it and using it. And we will get a lot better once we start getting the proms and start getting the ICHOM indicators as well. So I ask you to be part of the leadership. We're going to be designing the models of care. We've already done a lot of work in that. You've all done a lot of work in that. And we're really looking forward to having Martin joining us. I know that Richmond's not so keen, they're still sobbing. But we're looking forward to having Martin part of this so that he can help lead this value-based journey for the rest of us. So I'm now going to thank you finally, and now there is nothing between you and the drinks. And there is something. So I would like to invite you all to come out and have drinks with us and debrief, and really love to hear any of you come in with any of your brilliant ideas as well. So thank you.
Thanks, Deb. It's been a very stimulating day, so congratulations to you and your team for putting on a really good show. The program was very interesting, the speakers were all engaging, and I don't often say that at the end of a conference. It was really good. And thank you all for being a part of it. We have an evaluation sheet for you to complete. You can either fill out the one on your table or the online version, which will be sent out on Monday. Yes, there are some post-conference drinks in the foyer. Exchange your name tag for a drink, and then the name tag goes into the bowl to win some champagne or a copy of my book. So we've got some fabulous prizes to give away. It's been a pleasure being your facilitator today. I'll see you in the foyer. Thank you.